Hello, and welcome to the physical therapy portion of the online joint orientation at Good Samaritan Regional Medical Center. My name is Matt. I'm a physical therapist here at the hospital. If you have not watched the occupational therapy session done by Alan, it would be a good idea now to go back and watch that. Some of the things that I talk about here, or I'm going to talk about here in the next few minutes, build on subjects that he's discussed. I will begin mine, however, by echoing something Alan said, and that is that we all wish that we could be doing the traditional in-person joint orientation as we've done for years and years. I'd much rather be doing that than staring at a computer camera right now. I've really enjoyed those classes through the years, and I think that they've been really helpful for people, having them feel a little more prepared for surgery and also getting prepared for surgery. But this is what we've got, so we'll make the best of it. There'll be a lot of information thrown at you here in the next little while. Do not feel like you have to master it all. Just take in what you can. We sometimes joke that you're not going to have to pass a test after watching these to have your surgery. So with that, let's go ahead and get started. Okay, so a quick overview of a few of the topics that I'll go into here in the next few minutes. First of all, the very important preoperative exercise program. Talk a little bit about front-wheeled walkers and other assistive devices, and then move on to what a typical day and a half might look like while you're here in the hospital. Kind of wrap it up with a few miscellaneous items there at the end. I'll try to keep it moving. As you go to your preoperative visits at your surgeon's office, you'll be getting all sorts of information, written materials, including these three that you see pictured here on the screen. Two brochures, one titled Getting Ready for Total Hip Replacement or After Total Hip Replacement. Of course, if you're having a knee replacement, you'd get the brochure for the knee replacements. And then a loose leaf sheet of paper that has lists of exercises on them. Those two brochures there also have lists of exercises on the inside. They're not all identical, the list that is, but they're similar. And there's not one go-to list of exercises that you should use. You'll find that there's a lot of overlap between all of these lists. So try all your exercises, see which ones come very easily for you, see which ones are kind of moderately difficult, and see which ones are maybe more difficult than you should be trying to do right now. One of the common themes that you'll hear from me in the next few minutes, not only for exercises but other things as well, is just this concept of moderation. And that is that as you're getting ready for surgery and after surgery as well, you want to try to push it a little bit with your activities, but we really don't want you pushing past moderate levels of fatigue, pain, exertion. It doesn't mean you have to push it up to moderate levels, but that should kind of be the limit that you're thinking about. And this is kind of a concept that you probably have lived with for many years. Most of you who are having joint replacements are doing so because of degenerative arthritic changes in your joint. You've probably learned this lesson long ago, that I need to operate within a certain range of activity. If I don't get up and move around and move those joints, they stiffen up and hurt like crazy. And then if I overdo it, I pay the price on that end of things. So same things with these exercises too. Try them all, see which ones are reasonable for you to do. Start slowly and build up if you can. For those of you who really like numbers, down here on the bottom of the slide, I would say 10 repetitions, 3 to 4 times a day. But again, that's just a guideline. You could do more or less than that if that's what your body is telling you is appropriate for you. So the common theme, regardless of whether you're able to do just a few of these exercises or maybe build up to where you're doing all of them and doing them fairly comfortably, is that doing these exercises is going to improve your outcome after the surgery. It really makes a difference being able to get those muscles around the joint that you're having replaced stronger before the surgery. You will thank yourself and you'll get great return for your effort investment, so to speak, after the surgery. If you can, though, back off a day or two before the surgery. Again, kind of going back to that theme of moderation. We don't want you trying to squeeze in a lot of activity. I joke sometimes, don't go out and mow the lawn and try to do all these chores right before the surgery to get ahead. We don't want you coming in on that day of surgery kind of flared up and painful. We want that to be one of your happier days, so to speak. So here we are at the moderation slide. I think I've already hammered this home, hopefully, but here you go. It's in writing, so it must be important. If there's just one thing I could tell you to remember out of this whole presentation, it would be get started on your exercises and do what you can with that. Consistency is the key, though. Just a little bit every day, what you can handle. All right, we've covered that. Moving on. Assistive devices. These are pieces of medical equipment that you use maybe now, but certainly after the surgery for a short time, you'll be using a walker to help you get around. Just so that we're clear on terms, even though I figure most of you have probably seen these pieces of equipment before many times. Front-wheeled walker just has the 2 front wheels and some type of stubs or skis on the back. You can stand up inside of the front-wheeled walker. Doesn't allow you for tremendous mobility, but gives you great stability. As opposed to the 4-wheeled walker on the right. These come in many different shapes and sizes, but this is a fairly standard picture here. Very nice for mobility, but not so great for stability. And really, they're not going to give you the stability that you need to safely and effectively get around immediately after your joint replacement surgery. So almost everybody will be using a front-wheeled walker after the surgery, in the days and weeks after the surgery. I say almost everybody, but for practical purposes, it's everybody. We're talking 99% probably. So your expectation really should be that this is what you'll be using after the surgery, which is a good thing. You know, walker is a very stable device. It allows you to have safety while you work in the days after the surgery on your gait pattern, giving you enough stability so that you can start avoiding these compensations that might want to creep in after the surgery. How long you should use the walker, common question I get, really depends on how well you're recovering from the surgery. So this could be a few days or it could be several weeks. The common theme here is that you really shouldn't get rid of that walker until you've gone through a series of days where you're basically not taking any weight through the walker. You've gotten to the point where your gait pattern looks very good. Essentially, the steps on either side look identical or very close to identical. Your outpatient physical therapist can give you feedback on them, on that, and she or he can give you her or his recommendations on when you should get rid of that walker. So shifting gears here a little bit, if you do use a walker presently, or a cane or a wheelchair, and you need that device to safely get into the surgery center, then of course use that device, get into the surgery waiting area, and then whoever transported you to the area, a family member, can take that back away home until you're ready to use it at home. We have our own equipment here, so if you don't need to bring that into the hospital to safely get to the waiting area, then don't. It's just one more thing that can get misplaced. If you plan to try to find a front-wheeled walker before the surgery, it's important that that walker is going to work for you. We like to verify that here in the hospital, but you can also do a quick check for yourself to see if that walker is likely fitting you properly. And here's a couple of pictures that go into that. The left picture, if you're standing near the back supports of the walker, standing with good posture, with your arms by your side, the top handles of the walker should come about to where your wrist is. If you then grab the handles, again with good posture, as in the right picture there, your elbow should be slightly bent, something like 20 degrees or so. Most people choose not to try to get a walker or borrow a walker before the surgery, and that is fine. We usually take care of the walker ordering once you get here to the hospital. So if it's not convenient for you, or it's not something that's feasible for you to do before the surgery, that is absolutely fine. The discharge planner, also known as a case manager here in the hospital, will take care of that, give you information about that once you get here at the hospital. It will actually be delivered directly to your room before you leave the hospital. It's such a common piece of equipment that we have stores of them here at the hospital. And how long are you going to be here at the hospital? Well, there's two simple ways to answer that question. First, most people leave the day after surgery. And the second simple answer is that you will discuss this with your surgeon at your pre-operative visit, kind of come up with a tentative game plan, so to speak. And very likely that tentative plan will be that you will be leaving the day after surgery. We do have a few people that actually leave on the day of surgery, but again, this will be something that you will have discussed beforehand, and you know that that's your goal. Sometimes the best laid plans go astray, and that day after surgery, when you had hoped to leave, is a little rocky, and this is definitely the exception, maybe the rare exception and not the rule. But if that is the case with you, then you will discuss this with your surgeon, your nurse, definitely input from your therapist, and if you need to stay a second night, then so be it. I've been here for 14 years and that's never been a problem before in the time that I've been here, having a patient stay another night if that's what's really best for the patient. With that said, if you're doing well and you're able to leave on time, you really should leave on time. Not only is home likely to be a more comfortable place for you, but if you don't need to be in the hospital, then you should go ahead and leave the hospital. All right, finally, some straight up physical therapy for me to talk about. I will probably, or a physical therapist like me, will probably see you 2 or 3 times while you're here in the hospital. Most of you will have a morning surgery, and your physical therapist will try to see you for your initial visit that afternoon, depending on when you were able to get out of surgery, out of recovery, and make it up to the floor, to your room. We start with that initial visit with just trying to get a big picture of where you were before the surgery, how active you were, what are some of your goals going forward, special circumstances, what is your home setup like? Is it a multi-level home? Do you have stairs? Who do you live with? How much is that person or people likely to be around right after the surgery? All of these are factors relating to your safety, and maybe factors with how quickly or slowly we choose to progress things or set goals to progress things right from the start. Progressive mobility. This is true not only for the first initial visit, but every visit thereafter. I'm not ever going to come into your room and say, on visit number 1 or visit number 2, this is the amount of activity that we have to do. No, we start with the simplest thing, which is just sit up on the edge of the bed. We see how you feel with that. If that goes well, we stand. If that goes well, we walk, and so on and so forth. Usually, on the very first visit, just a few hours after surgery, most patients are able to sit up, stand up, even take a few steps, and feel pretty good doing it. And then we just ramp it up from there as your body is ready the day after surgery. Right from the start, we're safety first, right? Right from the start, we're going to try to give you feedback on some of the things that you need to watch out for. So for example, if you're having a hip replacement, right from that very first visit, we're going to be working on how do you move around while staying compliant with those hip precautions. How do I support myself in the walker if my leg doesn't feel like it wants to support me right off the bat after a knee replacement? Things like that. That's always going to be at the forefront of what we're trying to do. Safety first, and then progress your activity within those safety parameters. And then with subsequent treatments, we'll kind of get into a little more of the nuts and bolts that people usually associate physical therapy with. Therapeutic exercises. These are essentially going to be the same exercises that you were doing preoperatively. You might find initially postoperatively that you're not able to do all of them, but the difference is after surgery you'll just get better and better with it. That can't always be said before the surgery, right? Strength and range of motion, especially for those of you who are having knee replacements, it's essential that we get that knee moving. We work on the flexion, the bending, and we also work on the straightening. Those are equally important. Your physical therapist will give you feedback on how aggressively you need to be working with that. You can overdo it, and sometimes you need to push it harder. So your physical therapist will have that perspective to be able to give you that feedback, that insight. Safe use of walker, safety first, right? I've said it 3 times now, I guess. But also just working on posture and balance, working on those gait deviations, trying to iron those out right from the start. And finally, maybe the most important thing from my view is establishing recommendations. The way I look at my role is maybe the most important thing I can bring you is just the perspective of having worked with hundreds of patients over the years. I mean, those therapeutic exercises, it's not rocket science, right? There's a right way and a wrong way to do it, but that's probably not the most important part of my job. But maybe the most important part of my job is to let you know that, hey, these are the things that you're doing well with. See, these are the things that you're a little bit kind of behind the curve on that I think you need to spend some extra time with. And this is the way that you spend that extra time with. This is how you address that little deficit that's potentially forming there. Also, very importantly, staying in that proper range of activity. We say it over and over, try to do as much as you can without overdoing it, but where is that range? Well, hopefully I can give you some insight on where I think that range is in those early days after the surgery based on how you're doing. So some of this on this slide is a bit of a review, but what is the day of surgery going to look like for you? Morning surgery in all likelihood, PT visit in the afternoon. Whether it's with physical therapy or with nursing, the expectation is that you'll be out of bed for all meals and toileting. That goes for whether or not you're doing a lot of activity. A lot of activity would mean you're able to get up and go for a walk in the halls, for example, or just a little bit of activity. And my definition of that would be that, you know, sitting on the edge of the bed and maybe just moving over to a chair. But we want you up out of bed, whether you feel great doing it or maybe not so good. The common theme is that if you're able to get in that early activity on the day of surgery, it's going to make the day after surgery a lot smoother for you. Kind of an aside, sometimes physical therapy cannot get to patients on the day of surgery. Let's say you had a later surgery or things got backed up. Physical therapist does not need to be the first person who gets you out of bed. The vast majority of you, 99+% of you, are going to end up on the 3rd floor after surgery, which is our orthopedic floor. You will be working with nurses and nurses' aides who have a lot of experience working with total joint patients. So it is very common for nursing to get patients up many times throughout your day or two here in the hospital. And it's not uncommon for the nursing staff to be the first person to get you out of bed even before the physical therapist. I'll also mention that anesthesia and surgical procedures have come a long way in the last couple of decades. I mentioned that I've been here for 14 years. I've been a therapist for over 20, and 20 years ago, when I would go see a patient on the day of surgery or even the day after surgery, it was often not a very fun activity for the patient. A lot of times it would be lightheadedness, nausea, knees buckling when we tried to stand up, and all of those things are now thankfully the exception, sometimes the rare exception. But if you're having a little bit of a rough go of it, that few hours after surgery when I see you for the first time, It can be very easy, and I totally understand why you might want to question, why are we doing this? I just was done with surgery a few hours ago and I really don't feel very good right now. The reason we do that is because if you're having a rough go of it that first time up, chances are that if we waited till the next day to do it, you are going to probably have the same reaction. And I know that's easy for me to say. I'm not the one going through the difficulties, but if we can kind of see where things stand on that first day, if you are having a rough time, we can kind of put our detective caps on and try to figure out why you were having that reaction. Was it a drug? Was it blood pressure? There's many other things that could be involved, and we can try to figure that out on the first day so that the day after surgery you can really get things going well, instead of that day after surgery being the one where maybe you weren't having such a good day. All right, so wrapping up during your hospital stay, the day after surgery, you'll have 2 physical therapy sessions available to you, one in the morning, one in the afternoon. Sometimes patients are doing so well after that morning session that an afternoon session really is not needed, and the patient's able to leave midday. Much more commonly, though, we would want to try to get to you twice that day after surgery, even when things are going well. They're not scheduled per se, but they're loosely scheduled, let's say. Your physical therapist will communicate with your nurse to see when you were medicated for pain, when your meals were, and we will try to see you in a way that makes sense with the other activities that you have going on that morning. As mentioned before in Alan's presentation and also this one, we want you moving around consistently throughout your waking hours. Moving around every hour or two does not mean that you get up and go for a long walk every hour or two. It simply means that you get in some body movement. That might mean a walk. It might just mean sitting up on the edge of the bed or sitting up for a meal or a short walk to the bathroom, for example. We just don't want you staying in the same position hour after hour. It's not good for your hip or knee that was operated on, and really it's not good for the rest of your body that's trying to recover from anesthesia. Okay, this is the last informational slide. We're almost done, I promise. Just a few miscellaneous topics to cover. This slide I've had in my presentation for years. This information actually is written in the pre-COVID pandemic world. I think the information is still valid, but please understand that sometimes our rules regarding the hospital rules regarding visitation may change from week to week, month to month, depending on where Benton County and surrounding Oregon counties are in regards to the pandemic. With that said, I'll start by saying it's a nice idea, if possible, if you feel comfortable coming into the hospital, to have a care partner here for at least one physical therapy session. More if you'd like. I don't think it's necessary to have more than one, but here for that one visit towards the end of your stay, when you've had a day to see how things have gone, a day to come up with questions perhaps, can be very helpful. Consider limiting visitors. That's kind of been forced upon us in a way, but even before the pandemic, I think it is a good idea. It was a good idea to not overwhelm yourself trying to entertain visitors. Post-surgically, for the first few days, this can be a very tiring process. I really think your energy perhaps is better spent focusing on your activity, and then between your activity sessions, getting good quality rest. So yes, it's great that you have people who might care about you enough to visit, but if those visits can maybe be pushed back a few days, you might find that that really helps you feel more rested. Rest that's going to be important for you in those early days. And last but not least, I want to mention, it's certainly been mentioned elsewhere, but please use your call light every time you get out of bed, even if you're doing very well. So real briefly here, I want to talk about a CPM machine. CPM stands for Continuous Passive Movement Machine. This is a machine that was commonly used after a total knee replacement 10, 15, 20 years ago. It's really been phased out as a typical standard of care piece of equipment over the years, as it's been found more effective for patients to be up and actually moving around, actively doing exercises, rather than using this machine. I'm not really going to go into it in any great detail here, simply because only a very, very small percentage of you after your total knee replacements will be using this machine. If this is something that you or your surgeon feels should be used, that will be discussed in your preoperative visit. And this really is the last slide. Thank you again, sincerely thank you for choosing Good Samaritan, for sitting through this presentation. I promise, if you've ever been to our in-person joint orientation class, we try to make it a lot more interesting and a little more fun than just staring at a computer screen. So thank you for taking the time, and I really hope that I'm able to meet you when you're here at the hospital. I think you're going to look back in the weeks and months after your surgery and be glad that you did it. Take care.